Hi, welcome to our educational forum on cervical radiofrequency neuroablation using Coolief cooled radiofrequency technology. In today's procedure, we're going to take a lateral approach in order to perform the ablation. We want to make sure that we optimize position of the patient prior to beginning the procedure. A major drawback in this case is the down shoulder, as you can sometimes see a shadow within the fluoroscopic image. In our initial fluoroscopic views, we can clearly delineate between the skull, the C1 vertebrae, C2 vertebrae, C3 vertebrae, and C4 vertebrae. As we start from cephalad to caudad, our first target is going to be the third occipital nerve. The third occipital nerve lies at the junction between the second and third vertebrae, right in this position. What we want to do is we want to make sure that we provide adequate local anesthesia to decrease patient movement and limit our fluoroscopic viewing time. When we initially anesthetize a tract, we don't want to go too deep. The target is very shallow, and we only want to use a 27 gauge half-inch needle if possible. We do not want to anesthetize the medial branch because obviously that would ruin any motor testing that we have, which helps to ensure the safety of this procedure. Our initial track to anesthetize is typically a down the beam approach towards this area. Here, I take a down the beam approach and provide local anesthesia towards the C2-3 joint line. After I've anesthetized appropriately, I'll take the 17 gauge cooled Coolief radiofrequency introducer, place it over the skin that I've initially anesthetized, and move it in a down the beam approach towards the C2-3 joint line, moving it several millimeters at a time. I will touch down on periosteum, and then I will remove the stylet. This will keep the introducer superficially suspended off of the periosteum. I will take the probe and I will screw it to the introducer via the Luer lock system. And then I will begin motor stimulation at 2 Hertz to 2 volts. Any twitch response is considered a positive response and would necessitate moving or repositioning the introducer. After we are ensured that we have no twitch response, we can use the side port located on the introducer unit to instill local anesthetic. Once we have achieved an appropriate depth of local anesthesia, then we can move forward with radiofrequency ablation. The radiofrequency ablation parameters are 60 degrees centigrade for 2 minutes and 30 seconds. The 60 degrees centigrade cool temperature equates to an 80 to 90 degree adjacent tissue temperature, allowing for sufficient neuroablation of our targets. At the conclusion of radiofrequency ablation, we can remove the apparatus at one time. However, when we are ablating at the C2-3 level for the third occipital nerve, we can merely remove the probe, reinsert the stylet, and reposition through the same insertion site down to the superior aspect of the C3 lateral mass. By slightly retracting our introducer, we can then make movements towards the superior aspect of the C3 lateral mass until we touch down on the top half of that C3 lateral mass. Again, once we've achieved touchdown on periosteum, we can remove the stylet, place the probe and screw in the Luer lock, and then motor test at 2 Hertz to 2 volts. Once we've achieved a non-twitch response, then we can move forward with radiofrequency ablation at the same parameters as we did for the third occipital nerve. For the C4 medial branch, this branch lays more towards the mid part of that lateral mass. After we have obtained appropriate local anesthesia at the skin, what we can do is move in a down the beam approach towards the mid aspect of that C4 lateral mass. Once again, this is very superficial. And we would have a final position in this case. One of the beautiful things about the Coolief cooled radiofrequency technology is we don't have to be perfect. The technique is set up so it can be performed safely, and we can allow the quality of the lesion or the volume of this lesion to allow us to optimize our neuroablation. Once again, the stylet is removed, and the probe is placed into the introducer and secured with the Luer lock. Another fluoro image to verify appropriate position. Move ahead with our motor stimulation at 2 Hz to 2 volts, instill our local anesthetic, and then move forward with the ablation at 60 degrees centigrade for 2 minutes and 30 seconds. The remainder of the cervical spine can be performed in the same way. The only exception is at the C7 level, where the medial branch lies at the apex of the C7 superior articular process just above the transverse process. Once again, optimal patient positioning will help facilitate this needle placement. Thank you for watching our video today. This will conclude our educational video on cervical radiofrequency ablation using cooled Coolief technology in the lateral approach.